Very good evening, respected speakers, Dr. Raghu and Dr. Ganapathi Bantwal, and my dear doctors, respected doctors, and eminent doctors across the South Zone. And this webinar is going to take place across the South, that is Telangana, Andhra, Karnataka, Kerala, and Tamil Nadu. I will just take 5 minutes of your valuable time through our corporate presentation. Ajanta always looking beyond the challenges, embracing tomorrow. So here is my mission. We are serving global healthcare needs with empathy, innovation, and technology. And our philosophy is Enterprism, that is the art of creating opportunities and optimizing them. Company has always been in pioneering and innovative as in its efforts as well as to service the mankind. Our global presence is across the globe. In India, around 32% business, and Africa it is 26%, US it is 14%, and rest of Asia 26% sales have been contributed in 2019. So our employees are approximately 7,500 plus. A team of 28 different nationals are being part of Ajanta team. If you look at India business, we have products like Metexcel entire group, EcoSoft, Fabric, and Milacare, and EcoSoft entire range available. But if you look at the total products, we have 350 plus. Our vision, our divisions are 15, and the segments, we have different segments, and approximately 3,000 medical reps have been working. We are present in cardiology, ophthalmology, dermatology, pain management. The contribution, if you see, cardiology we are at 43%, 25%, 18, and 8%, so on. And among the top companies in the we are among the top companies in cardiology, and these are all the eminent products in our portfolio: Rosufit CV, Rosutar Gold, Atorfit CV, and Metexcel. And in different divisions, we have total 43 products. Among that 43, we are first in market in 22 products. You must be very familiar with Metexcel, Rosufit CV, Atorfit CV, Rosutar CV, Rosutar Gold, Synode, Silametexcel, and Vertigen. Approximately 1,000 plus medical reps are working only in cardiology segment. We are among top companies in cardiology, and with the 4 teams, and these are all the eminent brands, so I don't want to repeat again. Efonta is Efonidipine, and we are coming with the Vilatin, and then Beniflow. All these are the eminent brands available in our cardiac cluster. If you look at our pharma industry versus the growth, there is a consistent growth by Ajanta Pharma compared to the IPM. In almost all the years, 11, 16, 12, 18, 19, 14, 9, 22, 13, 13. In dermatology segment, we are on par, but in pain management, ophthalmology, as well as pharma market, we are more than the IPM market. About our infrastructure, we have 7 state-of-the-art manufacturing plants at Python, Dahej, Guwahati, Chikalthana, Chittagong, Mauritius, as well as Velis. Velis plant is basically an API manufacturing plant, and we have state-of-the-art R&D center as well. We do have the complete value chain. Around 750 scientists are being working in this for different departments. We have formulation development, analytical development, regulatory affairs, as well as synthetic development. Then if you look at our corporate commitment, we have been conducting diagnostic camp for eye camps, plastic surgeries, building social infrastructure, cataract operations, upgrading educational facilities, community marriages, skin treatment camps, blood donation camps, and family planning. In 2019 itself, we have done approximately 1 lakh free cataract surgeries to the needy people, around 6,000 plus family planning surgeries, around 13,500 skin and plastic surgeries, 35 school development educations, and around 56,100 students have been facilitated with education grants as a corporate philosophy. If you look at the recognition, we are proud to have been a top 500 pharma companies. Different journals have endorsed our presence in the pharma market, like Fortune, Business Today, Business World, Business India, ET, as well as Business School. And we have bagged many prestigious awards. Our Joint Managing Director, Mr. Rajesh Agarwal and Yogesh Agarwal, with Mr. Nitin Gadkari, when they have received one of the Giant of Tomorrow Award, with Prime Minister Young Makers of India for the year, and then Best Transformation for Best Corporate E-Governance. Then in Forbes Leadership Awards 2018, one of the prestigious awards we have received in 2018. And these are all some more awards in CNBC as well as Business World by Ajanta Pharma. So we are one of the best manufacturing as well as leading marketing as well as the state-of-art formulation company marketing in India as well as across abroad. So that's all from my side as a corporate presentation. Now, Madam, over to Dr. Veena.
Yeah. Good evening. This is Dr. Veena Venkatesh, working as General Manager Medical Services at Ajanta Pharma Limited. Today, the scientific session would be a novel combination of Efonidipine and Telmisartan in the management of hypertension. Today, we have with us eminent speakers from Hyderabad and Bengaluru. I have a privilege of introducing them to the audience. So first, today we have with us Dr. C. Raghu. Dr. C. Raghu is a cardiologist who specializes in interventional cardiology procedures. He is a pioneer in transradial and complex coronary angioplasty stent procedures. Over the past 2 decades, collaboratively has performed more than 40,000 coronary diagnostic procedures and around 20,000 coronary interventions procedures. Srimati Kirpal Kaur Memorial Gold Medal 1992 being the most compassionate towards his patients at AIIMS, New Delhi. Sri Krishna Memorial Gold Medal 1998 Best Clinical Research Work at the Cardiology Society of India, AP Chapter 1998. Been awarded with the Best Young Interventional Cardiologist in 2007 at the Sing Live Conference for the year 2007 Singapore. Best Peripheral Vascular Intervention Case Award at the 7th Asia Pacific Vascular Society meeting at New Delhi. Andreas Counting Award for the Best Chronic Total Occlusion Angioplasty at Indo-Japan CTO Meet 2016, Kochi, India. And next we do have the other speaker, Dr. Sree Bhushan Raju. He would be joining soon. Dr. Sree Bhushan Raju joined Nizam's Institute of Medical Sciences as a faculty in July 2002 after obtaining DM degree from prestigious AIIMS, New Delhi. He was a recipient of Professor H.L. Tridevi Gold Medalist in DNB Nephrology in the year 2002. He received the fellowships from Indian College of Physicians, Indian Society of Nephrology, and Indian Academy of Clinical Medicine. He has published over 30 papers, including 7 chapters, and presented around 50 papers in various national and international conferences. He is one of the principal investigators of CKD task force by Indian Council of Medical Research to evaluate the prevalence of CKD in an adult urban population in India. He is one of the very few specialists with MBA in healthcare management in the country. And we do have another speaker, Dr. Ganapathi Bantwal. Dr. Ganapathi Bantwal is a reputed and experienced endocrinology practicing in Bangalore, St. John's. He's a professor and head of the Department of Endocrinology at St. John's Medical College and Hospital. He has been the principal investigator in over more than clinical trials and many studies. He has published several papers in peer-reviewed index journals in the national and international level. He's been the ex-General Secretary, Endocrine Society of India, past Vice President, Endocrine Society of India 2012-13, past Vice President KRSSDI 2011 and 12, past Joint Secretary KRSSDI 2010 and 11. With the brief introduction of the speakers, I would like to hand over the session to Dr. Raghu. Sir, you can please take over. And a request for the delegates, please put the questions in the chat box. Once the talk is over of all the three speakers, then the question answers will be addressed. Sir, over to you now.
Good evening, everyone. At the outset, let me welcome all the participants for this webinar. Am I audible?
Yes, sir, you are audible.
Yeah. Okay, thank you.
Yes, sir. Yes, sir.
Okay, thank you very much. So, this evening we are going to have this new molecule of or a new combination, I would say, a combination of a calcium channel blocker with an angiotensin receptor blocker on behalf of Ajanta Pharma. We all know that hypertension is a very major problem in our day-to-day practice, and we need to treat it very effectively to reduce various cardiovascular as well as renal and neurological complications of hypertension. So this can be effectively achieved by using a combination drug, as we see as we go forward. And today we have a novel and a good combination of Efonidipine and Telmisartan. I would start this presentation with a brief introduction of these two molecules and how they work as an ideal combination, because this combination will help us to control blood pressure very effectively. But at the same time, nowadays, like all our diabetic medications, we are looking for other effects of the anti-diabetic drugs. We want a combo deal for majority of the drugs. So we are looking at a medication which is not just only controls hypertension, but we need to have a ancillary or sometimes a primary or a close near to primary benefits, like what we see for the drug alone. If we are using for hypertension, we need the drug to be effective against many other diseases. That is what is the concept, what is going on in medicine now. So now first go on to the molecule called Efonidipine. This Efonidipine is a calcium channel blocker. It's a long-acting calcium channel blocker, and if you can look at it, it has got an effect on the sinus node and reduces the heart rate and reduces the blood pressure. So what happens is, many times, for example, when you use a dihydropyridine calcium channel blocker, most of the time they cause a reflex tachycardia and vasodilatation. So that component is not there with this molecule. That's the first advantage. So whenever we give these calcium channel blockers, especially for control of coronary artery disease, for control of heart failure, we are worried about the reflex tachycardia, because that is going to be detrimental for us for the cardiovascular condition. That's the reason why we need a drug which controls the heart rate along with the blood pressure. So efonidipine, if you look at it, it works on the kidney at the glomerular level and acts both on the afferent and efferent arteriole and causes a reduction in the intraglomerular pressure, reduce and protects the glomerulus from the hyperfiltration hyperfiltration injury. It acts on the T type of calcium channel blocker, and there is apart from being acting on the calcium channel blocker, it inhibits the release of the aldosterone. There is no increase in the blood pressure. The left ventricular mass index is also reduced, and it is a vasodilatory medication. Now coming to the renin-angiotensin-aldosterone system, we know that renin is from the kidney and angiotensinogen, and from the juxtaglomerular apparatus, the renin is released, which converts angiotensinogen to angiotensin 1, and from angiotensin 1 to 2, that is where our ACE angiotensin converting enzyme acts. And whereas angiotensin 2 has got a direct effect on the sympathetic as well as in the renal tubular sodium resorption, as well as aldosterone secretion and arterial vasoconstriction and antidiuretic hormone secretion. So the angiotensin 2 has got multiple levels of action. So what we are looking at when we give a drug, we want to block all these effects by either by giving a ACE, which converts angiotensin 1 to 2, or by giving an angiotensin receptor blocker, which acts on the AT1 receptor. So that is what this group of drugs, we all know that the ACE inhibitors and ARBs, of them we continue to use prefer ARBs because these drugs have got a direct action on the angiotensin 1 receptors, and because of that it reduces the sympathetic activity, it improves the sodium resorption in the kidney, it reduces aldosterone secretion, increases the if it is the angiotensin receptor blocker, it causes it acts against the vasoconstriction and reduces the antidiuretic hormone secretion. So with all these things, we all know that angiotensin receptor blockers will improve the blood pressure when we give these drugs. We have a lot of angiotensin receptor blockers in our practice, starting from losartan, valsartan, telmisartan, olmesartan, agilsartan, like that. But out of all these molecules, we all are, all the participants as well as the speakers will definitely agree with me that telmisartan is a drug which is proven and approved, and it is a very effective drug. It's the most popular molecule of all the drugs because it's a it gives a very good control of blood pressure and a persistent control of blood pressure all through 24 hours. That is the reason why majority of nephrologists prefer telmisartan, cardiologists prescribe telmisartan a lot, endocrinologists also to prevent the renal damage. They also tend to prefer telmisartan. So we have got two drugs. One is a calcium channel blocker, which does not have the reflex tachycardia and has all the benefits of calcium channel blockers. On the other hand, we have the angiotensin receptor blockers, which have got a multitude of effects, not just controlling blood pressure, but it has got effect on ADH, it has got effect on vascular vasoreactivity, it has got effect on left ventricular hypertrophy, sodium resorption. So it has got multiple effects. So angiotensin receptor blocker plus calcium channel blocker is a very good synergistic combination. And if you can see, the landmark trials also have shown combination of ACE inhibitor plus calcium channel blocker is a good drug. We tend to prefer mostly angiotensin receptor blocker because many of our Indian patients are troubled by the cough. So many of the practicing doctors tend to have a drug which has got least amount of side effects. That is how they prefer the angiotensin receptor blockers. Now, why should we give a combination therapy in this condition? Most of the hypertensive patients whom we see come with a little high blood pressure like 150, 100, 160, 100, 140, 95. So those people cannot be managed by a single drug. More than 1/3 of the hypertensive patients need 2 drugs or more to control hypertension. So of all the combinations, we all know that beta blockers are not a very favored agent for the control of hypertension nowadays because of its lot of adverse metabolic profile. So we are looking at antihypertensive drugs which control the blood pressure but with a favorable metabolic profile, and at the same time it should have a persistent blood pressure control effect. That is where a combination of calcium channel blocker and angiotensin receptor blocker is the best choice in these conditions. Now let us go to the both the groups of the drugs. If you can see, telmisartan has got a long half-life. Efonidipine or Efonta has got a little smaller half-life, but because being a highly lipophilic drug, it has got a long-term bioavailability of this drug. So even once a day dose is sufficient both for efonidipine as well as for telmisartan. So Ajanta Pharma has cleverly has combined these two drugs at a dose of 20 milligrams of efonidipine, which is the average dose of the efonidipine what can be tried to get a good control of hypertension, and telmisartan at 40 milligrams per day, which is a dose what we commonly use for the control of hypertension. So with this, what I will go quickly is to look at what are the cardiovascular benefits of giving this efonidipine telmisartan combination, and why we need to give this combination. We all know that 1 in 3 adults have got hypertension. About 35% of the people, even in India, have got hypertension. We know the non-pharmacological ways of managing hypertension. We know how blood pressure is a sequelae of various behavioral risk factors, as well as lifestyle, social determinants and drivers like globalization, urbanization, reduced mobility and all. Okay, one moment, I think I'm not able to. Okay. Are you able to see the slides?
Yes, sir.
Yeah.
Yes, yes.
Yeah, sorry. Okay. So hypertension is a consequence of metabolic as well as lifestyle changes what we are having, and hypertension can cause a lot of CV events. That is what we could see. So now when you look at the blood pressure definition of hypertension, the American and European guidelines are little different. The American guidelines give a much rigid control of blood pressure of 120 to 129 and more than 80 millimeters of mercury of systolic and diastolic respectively. And hypertension as more than 130 to 139 and 140 to 149, stage 1 and stage 2 hypertension. So the definition of hypertension is much more rigid or much more at a lower threshold in American guidelines, whereas the European guidelines stick with the previous definition of 140 by 90. But at the same time, we need to understand that hypertension, the target for the control of hypertension is to bring it to less than 130 by 80. In the past, we used to be a little more liberal in the control of hypertension, but now the goal for therapy is also rigid, as well as the level at the threshold for starting therapy is also rigid, because we understand that uncontrolled hypertension is leading to a lot of complications. Now, what is the drug of choice? Now, I will quickly go through the various subsets with which a hypertensive patient can present. One is an uncomplicated hypertension. As we have seen, majority of our hypertensive patients have got a much higher levels of blood pressure, so they need a combination of the drugs, and the best combination is to give an ACE or ARB plus calcium channel blocker. And because it's a single pill, and majority of the patients need a 2-drug regimen to reduce the side effects of the drugs, as well as to give a predictable control of blood pressure. So uncomplicated hypertension, the first drug as per the European Society of Guidelines is a combination of ARB plus calcium channel blocker. For example, let us say if the patient has got a previous coronary artery disease history, in those cases also, if you are giving a drug like Efonta, these drugs do not cause a reflex tachycardia. So you can give a CCB plus an ARB and a beta blocker also. So you can give a 2-drug or a 3-drug combination of ARB, CCB in the form of Efonta and a beta blocker, so that is a good drug. Now, what are the, because this is the common scenario what I see in my practice, people with CAD, people with uncomplicated hypertension, but at the same time, they might be elderly, they might be having underlying diabetes, they might be having a metabolic syndrome. All those things are adverse or beneficially affected by giving a calcium channel blocker or a angiotensin receptor blocker. So that is the way how nowadays we need to control the blood pressure, because by using a combination we are able to control the blood pressure and achieve the goals or target blood pressure and at lesser side effects. The major advantage is, in the past we used to give this medication separately. Nowadays we realize to improve the compliance of the patient, we are giving a fixed dose combinations, and those dose combinations, whenever we should use them with a complementary mechanism of action rather than having two with the same mechanism of action. So both the European as well as American guidelines indicate that we should use 2 drugs whenever we are initiating therapy for control of blood pressure. What is the advantage of combining Efonta with Telmisartan is it gives a 24-hour good control of blood pressure, and that is a major advantage because of Telmisartan is a long-acting effect, and it prevents the early morning surge of blood pressure, which is the common reason for cardiovascular events. And what happens is during the last 4 to 6 hours, majority of the drugs have got their effect of the drug worn off. But with the telmisartan, that final effect is also preserved. There are a couple of studies, mostly from Japan, which showed that in a combination of efonidine 20 to 40, and uh, given once daily, they had a reduced blood pressure and consequences of blood pressure of cardiovascular, cerebrovascular diseases. Now, compared to the baseline, obviously efonidipine is a very effective drug, especially in mild to moderate hypertension. If you have got a much more severe hypertension or moderate to severe hypertension, a combination of efonidipine plus telmisartan is a much better drug. Efonidipine, apart from blood pressure control, has got a good effect on endothelial function, and in hypertensive patients, it preserves the endothelial function. So also when you look at sartans, telmisartan has got more than 24 hours effect. You can give in a 40 to 80 milligrams dose, and renal elimination is very small. So that is the reason why when you give a telmisartan plus efonidipine, it is a good drug combination. And it has been shown that attempt CVD study showed that when you give telmisartan for prevention of cardiovascular disease, by looking at the biomarkers, it has reduced a large number of biomarkers. Apart from reducing the blood pressure, we can see that urine albumin creatinine ratio, plasma BNP levels, serum various biomarkers like adiponectin, HSCRP, EGFR are all favorably altered by the angiotensin receptor blocker. So apart from being a blood pressure reducing agent, it has got neurohormonal effects, because of which the angiotensin receptor blocker will have a favorable cardiovascular event profile. Now, now let us come to this one of a combination of these drugs. Like a combination of these two drugs controls the blood pressure effectively, both in the elderly as well as in young people over the whole 24 hours. It has got renal protection, cardio protection, cerebral protection, and reduces the arterial stiffness in hypertensive patients at a significant reduction of both systolic and diastolic blood pressure. With this, I thank you all for giving me this, and I will remain for asking for any questions, and we will give it to the madam for the taking on to the next speaker. Thank you.
Thank you very much, Dr. Raghu. So now the next talk would be Dr. Sree Bhushan Raju. Sir, I request you to take over the session. Dr. Raju.
He has not joined that, madam.
He's not joined?
Yeah.
He is there.
Is he there?
Yeah, Dr. Raju has joined, sir.
Joined? Okay.
Yeah.
Sir. Raju sir. Raju sir. Not seeing.
Can we call upon the third speaker?
Raju sir.
Can we call upon Dr. Ganapathi?
Yeah.
Yeah. Okay. Sir, Dr. Ganapathi Bantwal, can you please take over the session now? And then later on, Dr. Raju will continue.
Yeah. You're able to see the screen, no?
Yes, yes.
Okay. Good evening, all. Before I start, let me thank the Ajanta Pharma for inviting me to speak on this new molecule, Efonidipine with Telmisartan, the unique combination. Whenever a new molecule comes, the first thing we ask is it applicable in diabetes? Do we have evidence for that? So that's what I'm going to talk about. As you know, India is number 2 in the number of patients or people with diabetes. So in 2019, we had 77 million people with diabetes. And 2000 2030, the projection is 101 million, and 2045, it's around 135 million. So we continue to be in the number 2 spots for the next 25 years. So as you know, diabetes globally affects around 285 million people. It's around 6%. The projections which I have already told you. If we take hypertension, so that's seen in around 972 million people, 26% prevalence. The projections for 2030 is around 1.56 billion, approximately 29%, a 3% increase. And then you find that in patients with diabetes, hypertension is quite common. 40 to 80% of diabetics have hypertension, and diabetics are 2 times more likely to develop hypertension. So what is the problem? So they lead to end-stage renal disease. So more than 70% of the end-stage renal disease is attributed to hypertension or diabetes. And then diabetes leads to increased risk of retinopathy, which is the #1 cause for blindness in the adults. So it can also lead to peripheral vascular disease. Diabetes increases the risk by around 2 to 4 folds. And this risk increases proportionately in patients with high blood pressure. And also this combination, the deadly combination of diabetes and hypertension, you're 3 times more likely to have a cardiac event, 2 times more likely to have a left ventricular hypertrophy, and 3 times more likely to develop congestive heart failure, and 2 times more likely to develop stroke. So how diabetes and hypertension predispose to cardiovascular disease? So one, the genetic factors. So it's present in anybody, so that we cannot prevent it. Insulin resistance is present in diabetes. In fact, it occurs even before you are labeled diabetic. At least a decade earlier only you have the insulin resistance. And insulin resistance can lead to, it's a selective insulin resistance. So what happens is in the proximal convoluted tubule, you have increased sodium reabsorption. And once again, the insulin resistance leads to increase in the sympathetic tone because you have an increase in the heart rate. Furthermore, it increases the systolic blood pressure. And also it acts on the vascular smooth muscles to produce mitogenicity. So you get hypertension. Diabetes is associated with dyslipidemia, especially you have an increased triglycerides, reduced HDL, and increased small dense LDL. And obesity also is an accompaniment. Even though if you are not obese, you have abdominal obesity, and that can lead. So this whole combination leads to diabetes, hypertension, and this in turn can lead to accelerated atherosclerosis, endothelial dysfunction, vascular inflammation, vascular fibrosis, and arterial remodeling, which leads to both macrovascular and microvascular disease, and ultimately leading to cardiovascular disease. So the leading cause of death in patients with diabetes is cardiovascular disease. 60% of the people die because of cardiovascular disease. So how do they contribute to that? So hyperglycemia via the advanced glycosylation end product can lead to macrovascular disease. Via the RAS, which has already been elucidated by the previous speaker. And as you know, diabetes is an inflammatory disease, so that can also lead to inflammation and macrovascular disease. There's an increase in reactive oxygen species, and that contributes to both microvascular and macrovascular disease. And the microRNAs also can lead to the micro and microvascular disease. Coming to the pathogenesis of type 2 diabetes, this is from DeFronzo, the classical description, the ominous octet. So we, in the beginning, when we were learning, we used to know only 2 defects, insulin deficiency and insulin resistance. We only knew 2. And later on, we came to know that, no, there are more defects. So now we have the 8 defects. This actually came more than a decade earlier. Now they say there are more, 12 more. So you have 12 defects. So you have the decreased insulin secretion. You have the insulin resistance. You have the decreased incretin effect. For every pathophysiology, you have a molecule which is acting. For this, you have the DPP-4 inhibitors and the GLP-1, increased lipolysis, increased glucose reabsorption, you have the SGLT2, decreased glucose uptake. So drugs like TZDs can act here, the metformin can act here. Neurotransmitter dysfunction, you have the bromocriptine quick release, which can act here. Also the GLP can act here. Increased hepatic glucose flow, the main mechanism of action of metformin is here. And you have an increased alpha cell activity. You have a decreased beta cell activity and an increased alpha cell activity, as a result of which you have increased glucagon, and you have the DPP-4 inhibitors and also the GLP-1 agonist acting here. So coming to the treatment strategy for hypertension in patients with diabetes. If the blood pressure is more than 140/90 and less than 160/100, start with one agent. See whether they have albuminuria. If they don't have albuminuria, you can start with an ACE, ARB, CCB, or a diuretic. But then if they have albuminuria, you must start an ACE or an ARB. Now, suppose the blood pressure is more than 160/100. Start with two agents from the beginning itself. See whether he has albumin. The moment you have albuminuria, there must be an ACE or an ARB. So suppose you don't have, then you can start with ACE or ARB or a CCB or a diuretic. This combination can be done. So now you started this medication, see whether you are reaching the target. So if you have met the target, so then what you have to do is continue same therapy. If you are not meeting the target, add agent from complementary drug class. If you have used an ACE, you add a CCB or a diuretic. If you develop an adverse effect, you change to another agent. Assess BP control and adverse effect, then still not meeting the target or adverse effect using a drug from each of these classes. So then probably we are dealing with the resistant hypertension. So first thing is whenever you have a resistant hypertension, always rule out drug non-compliance, alcohol intake, excess alcohol intake, obstructive sleep apnea, and renal insufficiency. These are the four things you'll always look for when somebody has resistant hypertension. If you're able to control, good. So the moment you have resistant hypertension, you should add a mineralocorticoid receptor antagonist like eplerenone or spironolactone. What does the European Society 2019 guidelines say for patients with hypertension in diabetes? Lifestyle changes recommended. You should take less salt, 2.3 grams of sodium, DASH diet, exercise at least 45 minutes to 1 hour. So here they say RAS blockers rather than beta blockers and diuretics recommended for hypertension in pre-diabetics. So RAS blockers. So RAS blockers plus CCB are to be prescribed in patients with diabetes and hypertension. Home monitoring to be recommended. So we were talking about, Dr. Raju has already spoken about this. Nifedipine, amlodipine predominantly acts on the L type, and that's the reason you have this reflex tachycardia. So the moment some drug acts on the N or the T type, then you find this reflex tachycardia is not there. So that's the advantage. Secondly, so when you have a drug which is acting on both, so the L or the T type, so then what is happening is, so if you take amlodipine, it is predominantly acting on the afferent part. So these efonidipine will act on both the afferent and the efferent. So overall, there is no increase in the glomerular pressure. So it improves the GFR via this mechanism without increase in the GFR. So that action is not there for amlodipine. Secondly, amlodipine has a side effect of pedal edema, which is not there because of this unique action via its action on the T or the N type. Now coming to efonidipine on platelet and monocyte activation markers in hypertensive patients with and without type 2 diabetes. So they measured these markers known as the platelet-derived microparticles, which are less than 1 millimeters. They are an offshoot from the plasma membrane itself. And the platelet activation markers, CD62P, CD63, PSE1, annexin-5, soluble cell adhesion molecule, soluble selectins, ICAM1, VCAM1, P-selectin, and E-selectin. So between hypertensive patients with and without type 2 diabetes and control subjects, they were measured. So here what you find is the platelet-derived microparticles actually reduced in patients with diabetes. This is before and after. In the patients without diabetes, it was not significant. Now, if you see the patients with diabetes, once again, there is a decrease before and after. This is for the MDMP. If you see the CD62 and the CD63 in patients with diabetes, it reduced and it was statistically significant. These are the platelet activation markers. So they lead to increased atherosclerosis, increased thrombophilia. So these markers are actually reduced when you're giving efonidipine in patients with diabetes, telling that it has a good rheological property also. So the levels of the platelet activation markers before and after treatment with efonidipine were reduced. This shows that the administration of efonidipine in hypertensive patients with diabetes could prevent the complication by reducing the platelet activity and adhesion molecules. Another study, a small study, protective effect of efonidipine on renal function and arterial stiffness in type 2 diabetic patients with hypertension and nephropathy. So 40 patients type 2 diabetes with hypertension and nephropathy. They were randomly divided into two groups. So one group received 40 milligram of efonidipine and the other group received amlodipine 5 milligram per day for 12 months. So they measured the arterial stiffness using the cardio ankle vascular index, we known as the KV. So this, like you have what is known as a periscope where you measure the central aortic pressure. Similarly, you have an instrument, Valsera or something like that, which can measure this. So you can see here, the dark one is the efonidipine and the non-dark one or the open one is the amlodipine. So in these patients, you find there was an increase in creatinine, but not so with efonidipine. Urinary albumin excretion was not significant with efonidipine, but in fact, it did increase with amlodipine. So there were significant increases in creatinine and urine albumin and a significant decrease in the estimated GFRs observed in the amlodipine group, but not in the efonidipine group. So this is the GFR. So this is the efonidipine group, not significant decrease, whereas in the amlodipine group, it did decrease. And then the arterial stiffness actually reduced when you use efonidipine. So normally they take a cutoff of around 9. So the moment it comes below 9, that means the stiffness comes from, which is good, but there was not so much changes with amlodipine group. So then they also measured the oxidative stress, that is the urinary 8-hydroxy-2-deoxyguanosine. This is a marker of reactive oxygen species that reduced with efonidipine, but not so much with the amlodipine. Now, if you see the aldosterone level, which was highlighted by the previous speakers, the aldosterone levels came down with amlodipine, with efonidipine, suggesting that efonidipine has more favorable effects on renal function, oxidative stress, and arterial stiffness than amlodipine, which is only an L-type calcium channel blocker. Now, coming to why do we want to add telmisartan? So now this drug has an effect on PPAR gamma, like the glitazones. So now by acting on the glitazone, it can improve the insulin sensitivity, the insulin resistance comes down, and also it can have some beneficial effects on the lipids also. So the PPAR gamma is a ligand activated transcription factor that regulates cell growth, inflammation, lipid metabolism, and insulin sensitivity. So the PPAR gamma agonists limit glucose-induced inflammation in the proximal tubular cells. So it improves endothelial function, reduces glucose and serum triglycerides, improves the insulin sensitivity, and suppresses atherogenesis via its improvement in insulin resistant. So it reduces the insulin resistance so that the MAP kinase the pathway is not activated and the atherogenesis doesn't happen. If you see the properties, so telmisartan is a full-time PPAR gamma agonist like glitazones. So typically have agonists in the 150 to 200 range compared with the other sartans. So the Transcend study showed telmisartan, there was a 17% reduction in stroke. And in the on-target study where they combined telmisartan with ramipril, they found that they were equal in stroke reduction, but the combination is not good. Combination of ACE and ARBs is not good. That's what I meant. So salient feature, so it helps to prevent complications, favorable effects on oxidative stress and arterial stiffness. Telmisartan improves the insulin sensitivity, reduces glucose and serum triglycerides, improves the endothelial function, and suppresses atherogenesis. Thank you for patient hearing. So this combination is supposedly very good because of its dual action on the L and T channels, as a result of which it actually reduces, there is no change in the GFR. It continues to maintain the GFR. There is no increase in the glomerular pressure. So it has a beneficial effect on that. And because of this action, it also has less pedal edema. And the combination of efonidipine and telmisartan is synergistic. Not only it helps to control the blood pressure, but also probably it also will help in a holistic management, lipids, diabetes control, hypertension. So it can help theoretically in reducing this. Thank you for patient hearing.
Thank you very much, Dr. Ganapathi, for an excellent talk. Especially you have emphasized the combination of efonidipine and telmisartan very nicely. I think we can go to the third speaker, Dr. Bhushan Raju. Can I request Dr. Raju to please take over the session?
Yeah. Good evening, everyone, and respected Dr. Raghu and Dr. Ganapathi and all the people who have been participating in this webinar. And I'm very, very happy to be with you all today. And you heard a lot about the calcium channel blockers' role in control of hypertension, cardiovascular, and in otherwise. And also, I think I have to play a less role as a speaker now because everything has been said, and I just try to link between hypertension and the kidney, which all of you know about, but it is actually reiteration of the same known facts again and again, which is also equally important for us to know much about. Hypertension being the most common cause of mortality all over the world. It has been stated that 50% of the deaths were attributed otherwise also to hypertension in the entire world. So you just imagine if the disease called hypertension is not there, just imagine about the population of this country. And not only that, the youngsters are getting affected more predominantly, and prematurely they're dying because of the hypertension, which is uncontrolled because of the drug therapy or because of their own ignorance. If that's the case, then we are all supposed to know about hypertension, and every doctor should know thoroughly about the diabetes and hypertension. And as far as the kidney is concerned, the most common disease, the chronic kidney disease, which is the most rapidly growing diseases of the world. And knowingly or unknowingly, 1 in 10 people will be having a chronic kidney disease. So the most common feature underlying in patients with a chronic kidney disease is the hypertension. So after the diabetes, the hypertension being the second leading cause of etiology of chronic kidney disease. And interesting thing is that hypertension also causes a kidney damage. And as we see more and more patients with a chronic kidney disease, as they grow older, and they'll get hypertension. It also contributes to their progression of the renal disease. So it is also a risk factor for chronic disease, contributes to the progression of chronic kidney disease. And the chronic kidney disease, which it progresses, it worsens hypertension, which produces a vicious cycle in which the kidney damages rapidly. And most important thing for us is to know that hypertension prevalence is increasing all over the world. Around 20% of the people in the world are having hypertension. The similar kind of a number you'll get even in our country also in various epidemiological studies. But as far as the kidney is concerned in CKD, as the stage of CKD grows, probably from stage 1 to stage 5, the prevalence of hypertension also increases. From a stage 1, 35 to 36% to almost nearly 85 to 90% in those patients with a chronic kidney disease of stage 4 to 5. And you know that the most uncontrollable hypertension is seen in those patients who are having ESRD and on dialysis, that too especially hemodialysis. So very difficult for us to control. We use all our drugs which are available in our therapeutic armamentarium to control the blood pressure. Despite that, it is very difficult to control the BP in our group of people. And also the prevalence of hypertension also varies according to the underlying etiology of chronic kidney disease. And it's very, very well expected that the patients with a renal artery stenosis with a CKD will have a high prevalence of 93%. And despite being hypertension not being normalized in some group of people, still the kidney can get into a progressive mode. Diabetic nephropathy is significant, and polycystic kidney disease also, most of the people will have it. But interestingly, chronic interstitial nephritis patients with a chronic kidney disease will have a less prevalence of hypertension. And they get hypertension only when they become ESRDs or nearer to that or stage 5. But interestingly, even there, you don't see some hypertension in the chronic interstitial nephritis people. And And very interesting to note that these people will do without a single drug, and sometimes they get into hypotension if you really treat them aggressively during dialysis. So this is a very different group of people, and we need to know the reasons. It is the tubules and interstitial damage in them doesn't contribute significantly to their hypertension. It's very interesting to note that. And it is also, as I stated again and again, that this is one which contributes to the progression of the chronic kidney disease. Whenever there's some kind of an injury to the kidney and the glomeruli, number of glomeruli are less, we need to know that there will be some, as the previous speaker also stated, the endothelial dysfunction, the increased renin production, as well as the decreased sodium excretion with the retention of the water and the salt. And also there's the activation of the sympathetic nervous system, with which there will be water salt retention, with which extracellular volume expansion takes place. And also because of the retention of the water and the salt, sodium, there will be increased arterial stiffness and also increased peripheral vasoconstriction secondary to the endothelial dysfunction. All of them will culminate ultimately in the increase in the amount of hypertension. So what are the contributions of hypertension in the patient with chronic kidney disease? It contributes significantly to the progression. The most uncontrolled hypertension, the more rapid will be the deterioration of the kidney function. And the first thing what we tell the patient is to control your blood pressure. That's very, very important. If you can control your progression of the, if you want to control your progression, the first thing which you need to do is control your blood pressure. If you can control your blood pressure, then probably 2 to 5 years of your extra life to the kidney will be added to that. So it's very, very important to control the blood pressure by whatever the means and the methods and whatever may be the number of drugs that can be utilized. Not only that, the most common cause of premature mortality in the patient with chronic kidney disease is the cardiovascular. So we can prevent the cardiovascular diseases also by controlling the blood pressure, so that we can decrease the incidence of premature mortality in that. So how it decreases, it's a vicious cycle that contributes to the uncontrolled hypertension, more damage to the kidney, the more damage to the kidney, the more risk of hypertension, more cardiovascular disease, and more uncontrolled hypertension, again, the more cardiovascular disease. And it is actually the way that really produces it because of so many reasons which are associated with hypertension. So at the same time, we need to know that the effect of controlling the blood pressure is also equally good as far as the renal protection is concerned. There are various studies like MDRD trial, the REAM2 and the SPRINT, the latest, also had so many studies over a period of time, over the past 25 years and 30 years, we have been watching nearly so many articles coming up showing the efficacy of the control of blood pressure, how we can decrease slow down the progression of the chronic kidney disease. The classical MDRD, once the studies which was actually there done in 1994 showed that a good control of blood pressure in those patients who are on the intervention mode over a period of 2.2 years slowed significantly in those patients with the proteinuria is significant. That shows that those with the proteinuria of more than 1 gram had the more beneficial effect by controlling the blood pressure. The REAM2 trial also said the same thing. And the SPRINT trial latest also showed the similar kind of an activity, showing that the decreased cardiovascular disease and deaths in those patients with intensive control of blood pressure, which is also equally important for patients with a chronic kidney disease. Other studies, in African-American study of kidney disease, the ASK trial also showed the slowed eGFR decline in intensive group with a baseline proteinuria is more than 1 gram. Similarly, the renal protection was offered by the control of blood pressure in a significant way when we control the patient blood pressure, especially when they have proteinuria. That shows that the proteinuria is a surrogate marker of endothelial dysfunction, also cardiovascular disease, also the chronic kidney disease. That shows that if you can control the proteinuria, and in those patients with the proteinuria, the control of blood pressure is even more important than the patients who are having an insignificant proteinuria. So it's very, very important to intervene and individualize the patient BP control, very important. So again, some of the guidelines, and so many guidelines have been there, and though we take KDIGO as very important for us. In those without proteinuria, even 140/90 control is okay. But in those with a significant proteinuria of more than 1 gram, approximately, a blood pressure control up to 130/80 is equally important and more beneficial to the patient with a chronic kidney disease. And hence, we need to target a blood pressure control of 130/80 in those patients with a chronic kidney disease. So what are the treatment strategies? Though this particular cartoon and the table shows that the first line therapy in a patient with a chronic kidney disease is ACE inhibitor ARB, and second line, third line, fourth line. But I say that the first line, second line, third line, fourth line is ACE inhibitor ARB only for chronic kidney disease. And we are all biased towards the ACE inhibitors ARB. And even our own blood pressure will be given with our own control also. We use ACE inhibitor or ARB. For anyone who calls me up also, I say ACE inhibitor ARB. When ACE inhibitor ARB cannot be given to a patient with a significant impairment in the renal function, something like a stage 4 or 5 with a creatinine more than 3, 4, something like that. Then we add another drug. Immediately the one which strikes us is the calcium channel blocker. And of course, when the BP is uncontrolled, and in fact, after a certain time, we don't have a discrimination among the numbers, because we give each and every other drug which is available. I think nephrologists are the only people who will be managing the most toughest and the difficult patients with hypertension who do not get controlled by any other means, despite being on dialysis also, and very difficult to control the blood pressure. And most of the times it is the blood pressure that takes the toll in our group of people with IC bleeds, sudden myocardial infarctions, and congestive heart failures. And despite being on 3 or 4 drugs or even beyond that. So unfortunately, the control of blood pressure is difficult in our group of people. That's why we don't discriminate, and we keep on adding every drug. And we have an experience of adding each and every drug to control the blood pressure. Despite that, frequently we fail to deliver the goods properly to the patient. As I stated earlier, the nephrologists all over the world have a bias towards ACE inhibitor ARBs, which are the mainstays of therapy for hypertension control in chronic kidney disease. And they block the angiotensin conversion, and the ARBs completely block the angiotensin 2 receptors. And this blockade decreases the secretion of aldosterone, and hence there is a decrease in the peripheral vascular resistance, and so also the control of the blood pressure. As far as the kidney is concerned, the angiotensin 2 again blockade leads to the dilatation of the efferent arterioles and decreases the intraglomerular pressure, and hence decreases the proteinuria. It is a very, very simple sequence of events that take place in that. But coming to our second drug of choice after the ACE inhibitor ARB, or probably first drug of choice in those patients with a significant CKD, is a calcium channel blockers. We have 2 groups. As previous speakers also alluded to, it is non-DHP, the short-acting as the long-acting, and the cardiologists, we use a lot of verapamil and diltiazem, which we don't get into. We use the DHPs, which is amlodipine, cilnidipine, and benadipine, and efonidipine. And also we use some of the short-acting drugs like nifedipine, and long-acting activity of the short-acting drug called nifedipine. The conventional CCB classical drugs, the amlodipine and nifedipine, they block the L-type calcium channel blockers distributed in the afferent arterioles of the glomerulus. And that increases the interglomerular pressure. Probably it can contribute to the significant damage, and probably also to the progression of the kidney disease, which has been demonstrated by various studies previously, that the patient with given calcium channel blockers had a more significant problem compared to the patients who were given ACE inhibitors and the ARBs. So they failed to deliver the goods when they were compared with the ACE inhibitors and the ARBs. So the renal protection is concerned by decreasing the proteinuria and the control of blood pressure. We have a novel CCBs, the efonidipine, benadipine, cilnidipine, and cilnidipine, which can exert an inhibitory activity through T-type or N-type calcium channel blockers, in addition to the L-type calcium channel blockers. So because the T-type calcium channel blockers prevail at both afferent and efferent arterioles, inhibition of these calcium channel blockers can dilate the afferent as well as efferent arterioles, reduction ultimately in the intraglomerular hypertension. That shows it is a renal protective. It not only dilates the afferent and the efferent arterioles, GFR will be further increased, and also the proteinuria will further decrease, which is also a surrogate marker. As stated, if you can decrease the proteinuria, you are almost indirectly improving the graft kidney function. And some of the studies also showed that the treatment with the L and the T-type calcium channel blockers, something like a benadipine, efonidipine, and manadipine, is associated with better renal outcomes than treating those patients with the L-type inhibitors alone, like nifedipine, amlodipine, and nicardipine. So it's very, very important for us to know the efficacy of these molecules. And renal protection with telmisartan is very well known, and there is no comparison. In fact, we try to write a telmisartan or any ACE inhibitor ARB of choice, and which increases the renal blood flow. And among the ACE inhibitor versus ARB also, we try to go more towards that ARB. Probably it is a fashion, and whatever is the new fashion and technology that comes into the market, we try to go with that. And among the ARBs, the telmisartan has actually taken a major share as far as the treatment therapies of hypertension is controlled, and it increases the plasma flow and decreases the renal resistance. And the renal protection is very important with the telmisartan, and it's very efficacious drug. It decreases the proteinuria over a period of time and for up to nearly 1 year. And the microalbuminuria reduction has been demonstrated very well in those patients with a mild to moderate hypertension. And also in those patients with a chronic kidney disease, it is known to retard the progression secondary to the hypertension control. So how superior is efonidipine compared to the others? We have some studies which showed, and some of them were actually mentioned in the previous studies, also showing the significant decrease in the cardio ankle vascular index, and there's no significant change in the amlodipine group was observed in those patients who were given efonidipine, which is also a T and L type calcium channel blocker, and renal function as well as the arterial stiffness. And also that in this particular other study also showed it efonidipine improved the renal function and decreased the proteinuria in elderly patients. That is called Zato study. The conclusion is efonidipine but not amlodipine protects the renal function and improves the arterial stiffness in diabetic patients with the hypertension and nephropathy. And not many studies are available now because it's being a recent molecule, and not many are really keen in starting some studies. Probably next 3 to 5 years, we might get more and more trials in various groups of people and various stages of chronic kidney disease, various amounts of proteinuria, various groups of people with varied amount of risk for the cardiovascular disease. These are the people that should have been checked, but the time alone can really tell us how effective this molecule. So far, so good, and this particular molecule appears to be very, very promising, and we can utilize this. That renoprotective effect of this is very well proven in some of the studies which are done initially, and a combination of ACE inhibitor ARB along with this particular new calcium channel blockers is proven to be a beneficial effect, and we need to get more studies with the other ARBs, ACE inhibitor along with this particular new calcium channel blocker, and definitely so more and more studies are required to know the superiority of the efonidipine and compared to the other calcium channel blockers. Thank you very much for the kind attention and the patient hearing.
Thank you very much, sir, for an excellent talk, very informative talk as well. Sir, can we go for some question answers sessions? There are some couple of questions posted in the chat box. Can I ask the questions?
Yeah.
Yeah, a question from Dr. Sitaram from Sikandrabad. Some calcium channel blockers have experienced reflux esophagitis as an adverse event, especially so with the nifedipine. How does efonidipine score in this area? Is that a concern with the efonidipine really? Dr. Raghu?
Yeah. Obviously, am I audible?
Yes, sir.
Yeah, you are.
Majority of the calcium channel blocker, as you can understand, they are fluid level relaxants. So they cause some degree of reflux, but I don't think it is a significant thing. We need to attribute it to the calcium channel blockers as a whole. In my clinical experience, I don't see, I don't recollect any patient where we needed to stop or completely withhold temporarily this calcium channel blockers. I think it's not a major side effect of calcium channel blockers according to me.
Okay, so with the efonidipine, there are no experience, but otherwise it's not a major concern. That's what. Yes.
With efonidipine, it should be much lesser.
Okay. Dr. N.A. Zaidi from Hyderabad. Patient is on amlodipine, but he has maintained the target. Can this patient be shifted to efonidipine? Patient is on amlodipine, but he has maintained the target blood pressure. Is the requirement, or can they shift to efonidipine?
Depends upon the it depends upon the associated other clinical conditions, like Dr. Ganapathi has discussed about diabetes. Somebody has discussed, Dr. Raju has discussed about, Sree Bhushan has discussed about chronic kidney disease. So it depends upon the associated conditions based upon which we need to change the drug or not. We need to take a call. But nowadays, what we are looking at is the effect of hypertension is not the only thing. As I have told you, we are looking at beyond hypertension. What are the additional benefits I get? That's what I was telling you. We need a maximization of the various effects of the drug. So possibly in that circumstance, I would give a combination of drug therapy to reduce the combination. So in that way, when I look at beyond hypertension control only, I will change this drug to another agent.
Dr. Ganapathi, would you like to add on, or Dr. Bhushan, sir?
Okay, so now if the patient is having a blood pressure under control, I wouldn't like to change it. More so even if he doesn't have even proteinuria also. So even if he has a mild proteinuria, of course, then my first choice in a patient with diabetic will be ACE, ARB, of course. But then the patient is not having any proteinuria, blood pressure is well controlled. I think he could still continue with the same, because ACE, ARBs have also not been shown to be beneficial in the absence of proteinuria. And then there is no recommendation also to start an ACE or ARB just for hypertension. Of course, patients with diabetes are prone to develop proteinuria with time. But then if you take theoretically, initially with no proteinuria, other drugs are fine. So what we want ultimately is the goal, say less than 140/90, or now they say even less than 130/80 without the side effects. So that is my take on that. If the patient is well controlled, I wouldn't like to change it.
The other question is, has there any reported adverse events for this combination? See, because the individually, if you look into that, probably it's well tolerated, but combination, is there any concern of some adverse events?
There are some drug interactions which have been seen. For example, aceclummerol, that when you use, you have to be a bit cautious. Similarly, I think acarbose, there is a interaction with acarbose. Then I think similarly, there are 2-3 drugs with which it can actually interfere. So that thing we'll have to keep in mind when we use this drug. So that's what I know. Otherwise, the side effects are as like the other ones with lesser effects, especially the edema is really less with the F1 because of its action on the T channels.
So, Dr. Raghu and Dr. Bhushan, how can this molecule be compared with the Benidipine and Cilnidipine? Yeah, we know the market of Cilnidipine brands which are available already and all. How
Yes.
can we position between, how can we actually differentiate between these two molecules?
Before Dr. Raghu comments, I just give a small comment that my experience with other molecules other than nifedipine, amlodipine, and cilnidipine is very, very less. These are the only 3 molecules I use a lot, and I did not use many of them because you know that we get caught by our own conventions, and we don't just give in to the new molecules so easily many a times. And the old habits die hard. That's a statement given by us. So unfortunately, I don't have much experience with these molecules, especially the new molecules. I won't get an experience of it very frequently. But definitely, calcium channel blocker, cilnidipine, have been using it, and it is not as bad as amlodipine, but at the same time not as good as we expected or predicted in the initial few years of our experience with the molecule. So it's very, very important for us to know that this molecule is okay. As far as the pedal edema and other things are concerned, it is actually equally bad like amlodipine. So other than that, the control of blood pressure is equally good, and there's no complications, no problems, and the edema, except for the edema, rest of all the things are okay and acceptable.
Okay. Dr. Raju, Dr. Sree Bhushan, good. I would like to add a couple of points to what Dr. Ganapathi and Dr. Sree Bhushan have told. Is whenever we give these, whenever we give any calcium channel blocker, especially in a cardiac patient, what we, as I have already told you, is we are worried about some degree of reflex tachycardia, which is less with this agent. And as Dr. Sree Bhushan has aptly told, it's very, if you look at amlodipine as well as cilnidipine, both are effective in mild to moderate hypertension. So what we are practicing with the other co-speakers also will agree is, nowadays we don't give only one drug. We try to give a couple of drugs or 3 drugs to synergize them and give the best effect rather than thinking of only in a single drug mode. That's what I normally do. And that is what I would suggest to the audience also.
So the question is another question from Dr. N.A. Zaidi. COPD with Digimed PVC on amlodipine.
Pardon, sorry?
He has mentioned Digimed PVC, patient with hypertension and COPD.
Yes.
Can amlodipine, patient is on amlodipine, can such type of patients be shifted to efonidipine?
The same thing, like just now what we discussed, we need to look at what are the compelling indications for us to change from amlodipine to efonidipine. And I think when you are looking at the various metabolic as well as a combination of these drugs only, this efonidipine plus telmisartan gives you the best possible effect. So for a patient with COPD, efonidipine definitely can be given, and telmisartan also can be given without any risk of any thinking of any side effect of both these medications.
Okay.
See, this is a new molecule, and we need to invent the true indications for the application of this particular for the prescribing this particular molecule. And we need to really get to not only the head-to-head comparisons with other established molecules. Not only that, we need to prove that this molecule is very unique and distinct as far as the activity, beneficial effects, and the number of adverse effects are concerned. So it takes a long time, and probably a few more years. And as such, the literature is actually not sufficient enough to say any kind of a true indication that this particular condition, this particular drug only should be utilized. Kind of a thing, it won't come so easily. And moreover, among the antihypertensive drugs, it is even more difficult. And it is very important that we need a lot of literature to say that. But extrapolating from other calcium channel blockers may not be appropriate when we are discussing and talking about only one molecule. So it takes some time. And let us wait for a few more studies, and probably another 3 to 5 years we will be getting a little bit more.
Okay, sir. So, Dr. Raju, the point is well taken. But so much you mentioned in your talk also about the resistant hypertension. Looking into this combination as a CCB and ARB, how do you actually position? Would you like to position this molecule, considering the comorbidities?
Especially with the comorbidities of our patients, our group of chronic kidney disease with uncontrolled hypertension, where they require 4 or 5 drugs, what kind of a discrimination we can actually give? Any n amount of drugs, and in fact, we want more and more groups of drugs. Actually, we need to have the control of blood pressure from all 8 angles, or from 8 sides of the nature. Actually, east, west, north, south, and northeast, northwest, kind of a thing. From every angle, we want to attack the kidney blood pressure, so that we can save the kidney. Not only that, in fact, in the patient of ESRD and dialysis, saving the patient is more important. Despite having all these things, I'm telling you, the most of our times, and in every week, at least 4 days, we see one mortality early in the morning at around 5 o'clock, 7 o'clock, patient coming to us with IC bleed. And any patient who complains of headache, and we are trying to do something, and we are sitting beside the patient, and immediately the patient will throw a fit and shows an IC bleed in the CT scan. And in fact, with the bleed inside the brain also, they'll be talking to us very nicely, that we realize that, okay, it was a manifestation of external manifestation, took some time than the internal manifestation, which we failed to detect early. So it's very, very common. So, uncontrolled hypertension is such a common phenomenon that, as I stated, there's no exaggeration, that we see 4 to 5 cases every week. Of course, our number of patients are more, and we have 600 to 700 patients on maintenance hemodialysis. And we keep on recruiting around 100 to 200 patients every week and every month. So in that way, our mortality looks probably acceptable, but it is unacceptable as far as the control of the blood pressure and awareness of the BP control among the patient is concerned. It's very important for us to make them understand how important to not to miss a single tablet, and how to monitor the blood pressure at home. We have been telling so many patients, despite that. But taking each and every drug, we do a lot of trials of changing the molecules with one after another. Some simple complication of pedal edema, we try to change from this drug to the other molecule, other calcium channel blocker. We keep on checking. Then I realized that all the calcium channel blockers are equally good and equally bad. But I can say that Efonidipine in a retarded form probably is a more stronger in controlling the blood pressure when it is given more frequently compared to these amlodipine or long-acting amlodipine, cilnidipine, or any other dipines. So this is the kind of a thing which we see. And we use every other molecule, but I do not use the new molecules because I'm afraid to use that, because I won't concentrate on the patients. Only if they come back, then we have to repent. So that's the only one. But our patients will require 4 to 5 varieties, and I want more varieties of the different groups of antihypertensives rather than similar molecules in one group of antihypertensive called only calcium channel blockers. I don't really require 20, 30 molecules, but rather a different kind of a group of antihypertensive we require to control our group of people.
Okay, sir. So there are a couple of questions again, like people wants to know, Dr. Bandi Krishna wants to know how efonidipine is better than benidipine. These are the common, actually, the practical questions keeps coming actually when we launch the molecule also. How it is superior to benidipine, how it is superior to cilnidipine. These are the common questions actually we do face.
So what happens is, what we need to understand is, as Dr. Sree has told, you have asked the previous question of if a patient coming with resistant hypertension, what is the drug what you choose? So where Dr. Raju was telling about multiple drugs. But what happens is, these are the drugs when you are choosing efonidipine versus benidipine versus cilnidipine. I think it is very difficult for us to establish superiority of one molecule or another. But what we need to look at when I am choosing a particular molecule is, does this give me a once a day, to give the drug only once a day, so that the patient, the compliance of the medication is easy, number one. Number two is, does it have a safety profile which is superior to the existing calcium channel blockers? Yes, definitely. This has got better to compare to the cilnidipine and benidipine. The third thing is, when we are looking at something like a pedal edema, which whenever we use calcium channel blockers, like amlodipine, definitely yes. Nifedipine, definitely yes. Cilnidipine also yes. Like when you are giving a vasodilator, obviously if somebody claims that the pedal edema is less, I think we are asking, it is not practically possible. So what I would say is, if you are choosing a drug, choose a drug which works 24 hours. Choose a drug which will have the least side effect, best safety profile and least side effect profile. That is how you should choose, and that is where the new drugs are trying to be better over the previous molecules. And then finally, one more thing what I would like to mention is, efonidipine is a drug which has originated from the Japanese scientific literature. So these Japanese are not like the Western countries where they promote the molecule very aggressively. Japan is a little more conservative country, so you do not see the Japanese products to be promoted like what you see the molecules arising from the Western countries. So the awareness about efonidipine is less, is contributed to certain extent because of the country of origin of the molecule. I'm not sure which manufacturing or which company is manufacturing the molecule, but as a whole, if you see, a lot of good products originate from Japan, but they don't get too much popularized.
Yes, in the continuation of the same, Dr. Raghu, a question from Dr. Joy Thomas from Chennai. Which is the best agent using heart rate, whether it is efonidipine versus azilnidipine? Again, one more new calcium channel blocker in the market.
Because Efonidipine I did not use, efonidipine for certain patients, but I would say that theoretically efonidipine seems to be superior, but I cannot say for sure. One head on head, we cannot say so easy.
Okay. Sir, anybody in the panel would like to add? Because I think these are the parameters is generally they do consider physicians. One is the heart rate and second one is the pedal edema part. That should be
So
apart from the efficacy.
Yeah. That's the reason, Dr. Veena, is when that is the reason, when you have pedal edema, which is secondary to calcium channel blocker, it is not preferable to give a diuretic as a treatment for these patients. Instead, it has been shown that RAS blockade is a good way to block the side effect of pedal edema. So that is the reason why, if you see, the Efonta T has come into practice. So we need to overcome pedal edema not by diuretics, but by using a RAS blockade. That is what is the best way to treat the pedal edema.
Okay. I think we are done with the questions. And if PMT has any questions, and Mr. Srinivas, if anything to be discussed.
Thank you, madam. You can carry on.
Yeah, I think It was really a brainstorming session, I can say that, because it's a new molecule. As we all know that you all mentioned your the advantages of combining the calcium channel blocker and the ARB. And Dr. Raju, you nicely pointed out the resistant hypertension and the number of agents that should be added. And the Dr. Ganapathi, nicely you carried out the aspects of hypertension with the diabetes, which generally coexist as a comorbid condition rather in most of the hypertensives. And Dr. Raghu, very clearly you positioned the molecule and told about the comparisons with the other CCBs. I think it was real discussions. The audience also would have taken the points with this discussion, hopefully. And I thank you very much, all the speakers, Dr. Raghu, Dr. Ganapathi, Dr. Sree, Bhushan, Raju, for their excellent talk and excellent interactive session so far we had with this webinar. I think I request Mr. Srinivas, you can please close the session and then vote of thanks.
Yeah. Thank you so much, sir. Your valuable presence, and you have made this evening very wonderful and very informative for all the delegates and for